rather than just giving broad general overviews, we're looking at ways to, how do we take the time we've got here to get more functional knowledge into these meetings and make it a little more worth your while to teach you some things in Cerner. We're going to really start out here with documentation stuff, since we have put our documentation delinquency deficiency policy kind of on a hiatus since go live on August 1st. We've had to work through a lot of kinks in getting the reporting structure to a place where we felt comfortable really holding people accountable to that again. So we believe we've got those reports there, and we're getting ready to sort of do a trial run with those. But officially, that first week of April would be when the policy would go back into full effect based on MEC's decision in our last meeting. So that's 22, greater than 22 days as it sort of plays out is when you really hit the delinquency piece. Will they still get the 10-day deficiency report that they get to let them know they're over 10 days. And then so you'll officially become delinquent to 22 days and have the threat of suspension imposed at that point. So hopefully, bear with us. I think there'll be case by case working through those as we make sure all the kinks are ironed out in that report. So feel free to reach out to Beth and let her work with the teams to make sure everything we've got on there is accurate. But what Tara and I are going to do tonight is kind of walk you through how to look at your message center, how to find what documentation and orders are already sitting there, and how we can help clean those up in the time we've got left before that first week of April. So.
I just want to say that as April begins, if you all receive a letter from me that shows a delinquency, please feel free to dispute those. If you see something that is not yours or is not appropriate, we want to help through this process as we've just been able to start generating reports that we think are a little more accurate. Feedback is definitely encouraged.
All right, so Tara is going to do the driving here. I will try to do the talking. Tara can feel free to interrupt me at any point in time. But as you can see, you've got the message center, which I'm sure everyone is fairly familiar with if you're using the system. We wanted to highlight for you some of the key places to look for the different documentation and different tips. The biggest thing that I think everyone has got to think about is when you're looking at this and you're on your inbox, making sure that your display is showing you everything that's actually out there. So it defaults to a 30-day or 60 days for some people, 30 days. So if you've never changed that and you just left something sit in there long enough, it didn't go away, it just hid from you. So looking at this, you got your inbox, so that display, and Tara can show you again there how to change the display. There's different options. Interesting thing about load all works for documents, but if you are on orders and you hit load all, it's going to hit an error because you can only look at last 90 days. I investigated that earlier to figure out why we were having some issues with it. So that's your quickest thing, is especially because providers will be getting feedback that they haven't done something. I can't see it. So as we've been troubleshooting this, going, well, first look at your display and make sure you're loading back that far to even see everything. So you got any orders in there? Okay. So Tara's going to flip over and just kind of, so there's you've got the documents section there, which is where forwarded documents to sign, which is going to be if you have a scribe, you have a nurse practitioner, PA, any other APC working underneath you, that's where their documents are going to come in for you to co-sign. So we wanted to just show that. There's also under this document section, all CDI and coding queries from the inpatient side, coding queries will be coming into there. And as you can see, Tara demonstrating there, a CDI query. It comes in, it looks like a document. It will have, they have templates on asking you what the question is, and then being able to respond to that. We won't get into the weeds of exactly how to respond, but I mean, you can see from that example there, it's asking, a straightforward question over, can you, the acuity of the blood loss anemia. You can simply modify this, as Tara's demonstrating there, by clicking the modify button. And all you got to do is put an X next to it, just like we used to on the paper forms. You can put a check and sign it. You can put an X next to it and then scroll down and sign that document. And that actually, suffices for completing the query. One thing to know with CDI queries is if you don't capture that documentation as well in your subsequent notes, and you leave a diagnosis in there, like you can correct a diagnosis, but if you leave it in there the next day, then you're going to have conflicting stuff. So just be careful that you don't answer one query and then conflict it with the next day's note. Yes. And so from here, another way that I think is when you're getting these queries and you're like, I want to look in the chart, you've also got the option of the inbox view versus the summary view that can quickly give you a sort of mini version of the chart to look at documents and a problem list. And you can actually update the problem list from there rather than having to launch the entire chart. You could actually go in there, and if it's asking for a diagnosis that you needed to clarify or add, then you could go ahead and put in the problem list and then carry forward to your note tomorrow. So
Get to that again?
But
how do you get to that again?
So go back to inbox view. Yeah, so this is your standard view. When you open it up, you're in inbox view, and next to that, where Tara's cursor is, there's a summary view that clicks you straight into that without having to take the time to launch the full chart and pull up a whole separate window.
Then what do you click to get back to your list?
Inbox, that inbox view that's next to it. Yeah, so those two buttons right there next to each other toggle between those two views. I find that really helpful in the clinic as well. If you're getting a message in the clinic, that you can jump into the chart and see a short version of it, look at med lists, look at when their next appointment is and those kind of things without having to bring open the entire chart. Seems to be more efficient to me. And of course, those queries go in we're still in that document section of the left-hand side of the message center navigation pane over there. Queries go to the signed subsection, which you go right there, what Tara's clicking on. So just making sure everyone sees that. So there's a lot of different subsections in here, and of course they only expand out if you have things in them. So essentially, if you're checking to make sure there's documents, as you're getting some of these, you may notice that different sections come in there and different stuff flows to different places. Of course, you got documents to review, which is, typically things you're just being sent more to review than to actually, it's actually not your documentation, it's somebody else sending you something. Like, I know Dr. Marion is very good at sending all of his notes on my patients, and that's where they go. And so that's really helpful. I think Dr. Serdax does as well, and some of our consultants send those. So it's really helpful to see that as a primary care provider to know what's going on with the patient. But so you're moving down that message center navigation pane on the left, you've got the order. So orders would be the next thing. Go back to that. Sorry, we're having to jump around in here a little bit so that we have examples of everything. So in your order section, this is where all of your cosign orders are going to show up. And, that's, part of the thing we have to do. And it does fall in that report of things that need to get signed off within that 22-day window, is to get those cosigns. So that's where they're going. Running down the list there, the next piece, as you move down to that work items section, saved documents becomes very important. So this is if you're seeing patients and you're not finishing those notes at the time, but you're saving it and pulling it into a note, but you got to go back and sign it off later. In the beginning, we were seeing people accumulate pretty large saved documents sections here. So that's just something you want to be mindful of. It's really helpful to me to create those notes, stash them in there. That puts a time stamp on it of when you saw the patient so that you're not having to worry about that 3 days later when you try to finish that note. If you never created it and put it in your saved documents, it's going to stamp it whenever you created it, or you're going to have to manually change the date and time, which is a waste of time to me. But so having those in your saved documents lets you quickly from here modify that document without having to jump into the whole chart, make some finishing touches to it, and sign it off. But for the most part, that's where a lot of people's outstanding documentation is hanging out. Really quick to just hit the modify button and sign those. And then when you refresh, it'll be gone because it's completed. And you kind of got a work list there. If you're creating those notes and putting them in your saved documents, to me, it's kind of your work list of all the stuff I have to get done. And that way it's in front of you, face up. You're not at the mercy of this report to come and tell you, oh, by the way, you didn't get these things done. You're able to sort of see what all's out there waiting on you to finish it.
It's editable, right?
Yes. So when you go into that, you hit the modify button. Tara's cursor is, oh, that's it then. Don't hit that button. The modify button has a little magnifying glass on the paper there. But yeah, that's as soon as you click that, you can modify it, edit it right there without launching the entire chart. So I like to save my clinic notes as soon as I go out of the room, have enough in there that I remember it, and then I can go back and if I have to tweak some things. But if the majority of it's already done and you're just going in making some final adjustments and looking it over before you final sign it. But that way I know I've got all these things left to do.
So you use it, you save it and then you go back from there.
Yes. I think, yes, that's what I do. I think it's easier to manage rather than, because otherwise you're trying to figure out what it is you've left undone. That's harder. It's harder to figure out what you didn't do if you didn't pull it into that saved documents and have kind of a nice work list of what to go back and finish. The only thing you can't do is once you pull it into that saved documents, you won't be able to go back into the main chart in those working component pages where you started. You don't want to go back in there and try to do it there. Otherwise, once you pull into this, you need to only work out of this document and not be going back into the main chart to work on, which is a benefit, especially if you're seeing them in the hospital day after day, getting it pulled in there and then it's out of your way. So tomorrow you can see them again and start a new one, because until you create that note and pull in the saved documents, you can't do a new note.
What I'd be interested in is maybe finishing the note, 2 or 3 days ahead of time or later, I'm sorry. And so you're not really delving into that note at the time, or no?
Say that again. So when you,
if I saved it and put it in for, saved it on Tuesday and want to get it finished on Friday.
right.
And you're not, are you able to capture labs and all that other kind of stuff? And does it reflect that
that's
day?
one of the things that you have to be if you're doing it in the hospital, you have to do it on the day of service or you're going to miss out on capturing those labs. There's ways in which you can capture that more cleanly, but I'm not going to get into those right now. But yes, your auto text.
Let's do that in April.
Yeah, there's going to be some CME coming up, in a whole series of stuff to sort of put together more recorded tidbits on how we get better at all these different pieces. And we'll get, that's in the weeds that we'll cover then. But you do have to be careful. Your auto text and your last 24 hours obviously isn't going to pull, it's going to pull back last 24 hours from the time you input that auto text. So if you try to complete it 3 days later and use the last 24 hours, you're going to get the last 24 hours from, you know, the day you put it in and not from when the note was created. So that's one thing to be aware of there. All right. Anticipated, well, reminders, sorry, no, reminders is good. Reminders is actually where outpatient coding will be sending their stuff. So if you're primary care, you're in the clinics, you won't be getting it in the document signed section. They actually come through the reminders and asking, you know, telling you what you've left out or what you need to add in. So that's another thing. I think we did have some confusion. We've had some confusion with people who do both, wondering why they're not getting some queries and where they are. It's because they're looking and they really are coming to 2 different places for that. Last up there that's important for this documentation is anticipated documents. This is kind of can help you keep up with what's out there. I think, you know, operative reports and those things, I don't know how well that works for you all. Know when we admit a patient on the hospitalist side, residency side, we get an anticipated document for a discharge summary. And I think the ED it fires some anticipated documents when you all sign up for those patients as well, as my understanding. And so, yeah, anytime you have surgery scheduled, it's going to do an anticipated op report. So that there is some things built in the system. It is not the be all end all perfect system we would like it to be, but it is a resource to kind of help you know when you've completed things. And HIM, of course, is looking at this on the back end, just making sure too, they're working that anticipated list, making sure all those get cleaned up. Because even if you admitted the patient as a hospitalist, I may not be the one discharging it. So they're helping clean that up on the back end for us.
I can add right here, if you do get a query, you need to go straight into the chart. The patient's name displays automatically up here for you in the blue banner. So if you click on the patient's name, it will take you into the correct encounter number.
That is a helpful hint there to get into it, because as we know with fin issues, and that will be more in the weeds too of things we're going to cover, is how to avoid those. That is one helpful hint, is if you're if you're on that document and anticipated, it will always take you to the fin number that goes with that documentation, so you're not trying to search for it. Last thing we kind of wanted to work through was refusals. That is something we really, I guess, didn't have so much in the old system, and really having to put in new workflows and how do we manage all of that. The one thing from a documentation deficiency policy issue that we have is if you refuse those, but you don't manually assign them yourself, it still sets under you until the people that have to work the refusal bucket get to it and get it reassigned. So if you refuse it up at the last day, then you're going to then be having to, that one really isn't mine, but it's still going to show up on your report. So Tara's going to show you some ways to, if you do, I think best practice here is if you get something and you're pretty sure you know who it goes to, when you refuse it, you can assign to another MD. And actually on orders and documents, you can route it to the person it should have gone to. And that actually gets it out of your name and in theirs. So I think that's a helpful thing, that it really doesn't take that much extra time if you already know who it is, and saves a lot of time on the back end for folks that are having to clean those up. And like I said, it gets it moved to the right person to get it signed off faster, and gets our documentation completed.
Really?
All right, so real quick, where do the queries go? Where do you have a discharge summary to do, and then a clinic query? Where would we find that?
All right. So yeah, so it's kind of recapping to finish up here. So CDI and holding queries will go to documents section and the subsection sign.
We're trying to do that concurrent, right?
I mean, ideally, trying to get that done as quickly as you can. And then reminders for your outpatient coding will go to the reminder section, which is down there below save documents. And then anticipated documents down below that is where op reports, discharge summaries are going to be flowing in, and ED notes when you sign up for those patients there.
They can assign an office clinic note if they see there's absolutely not one on the chart.
Okay. Anything else, guys?
I have one other thing. I know e-prescribe is a big deal. People are concerned sometimes that their e-prescribe didn't go across. Under the heading of messages at the top, of course, I'm not a prescriber, so I couldn't display this for y'all, but it would appear in red and it could say ERX errors. I can send a screenshot, but it's routing errors. And if you click on that, it would tell you what script didn't go across and why. So anytime the providers contacted us and said, you know, Walgreens didn't get this, this is the first place that I would look and see if it gave us a reason.
All right, thanks.